Let's go on to the next. Khadija. Khadija is present, and then the HIFU team. I hope you are ready. After that, you are finishing as well.
Good morning or good afternoon. Good afternoon. It's Dr. Khadija again. I have a very interesting presentation today. Very, very controversial. It's a presentation that I learned so much from. Let's listen in. The role of Misoprostol and the dilatation and evacuation versus hysterotomy in second trimester, termination of pregnancies in patients with multiple previous scars, and the importance of still need for very close follow-up. So in this case, okay, so the patient review had a 32-year-old at 20 weeks to weeks gestation who was actually referred to me from a mission hospital because the mission hospital could not, they don't do termination, so they referred her elsewhere. Had a fetal anomaly and encephaly. Of note is that she had 3 previous CSs. Her first CS was also at term due to breach, and the baby had an encephaly. Unfortunately, it was undiagnosed, and the baby died immediately at birth. So the patient knew the trauma of an encephaly. It was a baby boy, the first one, then 2 girls, and this is also a male child. So the patient declined hysterotomy despite all the risks discussed, and she chose misoprostol induction followed by DND. So initial management plan was, according to the figure chart of misoprostol for termination, which I've put here on the slide, is that at 13 to 24 weeks termination, actually 25 to 26 weeks, she was 22 weeks, sorry. So 13 to 24 weeks is supposed to be 400 micrograms of misoprostol, either per vaginal, sublingual, or buccal, every 3 hours. But we were scared of the 3 previous scar. We halved the dose to 200 micrograms. Those 3 doses, there was no change to the cervix. So we went higher and gave 400 micrograms as for figure. At this 400, she developed some cervical changes. At least she was at least 2 centimeters dilated. With this, we were able to put an extraamniotic catheter and balloon it with APC for saline. And we monitored closely for signs of rupture, of course. She had a nurse attached to her. So the patient actually started hypercontracting around 4 centimeters, and at that time the balloon also fell. And she was really hypercontracting. We decided to do a DNE and not proceed with labor. So this was a surgical procedure, very ugly. We did a destructive one. We used spinal anesthesia. Theatre team was at standby for laparotomy. We did under ultrasound guidance, and fetus was evacuated piecemeal in a wheel forceps. At the end, we evacuated the uterus gently, and we had extra caution to avoid anterior wall. So the outcome was no uterine rupture complications, EBL around 500 mils, 800 micrograms of sublingual misoprostol given for stop. He was supposed to be in the hospital for 3 days of IV antibiotics and strict monitoring of vitals until we knew that he probably could have caused something. And so we needed to be very, very sure and repeat for milligram the next morning. I think at this point, I thought it was very successful. I was very excited. Even brought very fast to Tungani and shared this post, this write-up. And then I shared this case also with the sister hospital with my friend Dr. Kibandi, who had a similar test dilemma at Consolata. The other patient was at previous 22 weeks with the IUFD, and he was like, what do you do? So I told him about my case. He gave misoprostol and catheter, and it was successful. The patients expelled the fetus successfully. Then there was a retained placenta. Tissue for the DDNC for that, and it was successful. Now here's a catch with my patient. Came to review her the next day. Said she was complaining of some chest pains. Otherwise, was very stable, ambulant, eating. No abdominal pains or PV bleeding reported. SpO2 was 96% in room air. Of course, my mind turned to amniotic fluid embolism, which is a risk factor for obstructing DNE. We also noted that the platelets, remember I'd asked for a full hemogram post-procedure. Platelets, they have gone down to 90. HB had gone down to 9 from 12. So, of course, I was very concerned. She was saying the only problem I have is chest pains. Very concerned, ordered for a CTPA. It was negative, of course, to rule out for pulmonary embolism or inflammatory changes that could indicate an amniotic fluid embolism. Then we decided to do a CT scan abdominal pelvis, which showed air under the diaphragm, some hemperitoneum, and a very small bony fragment in the endometrial cavity, which was not picked on ultrasound. So I decided that, with the platelets going down, HB going down, chest pain, that traumatic irritation, I decided to do an X-lap. And the patient understood. We found a very small 1.5 centimeter posterior wall perforation, but it was actively bleeding. It was near vessel with some hemoperitoneum. It was very thick, like that of ectopic pregnancy, because of I think she was trying to clot it up. So we didn't open the front of the uterus, we just increased the perforation slightly. We removed the bone fragment directly under visualization. We did an endometrial washout, and then we repaired the perforation site. So we did an abdominal washout. Patient was very stable. Just for another 2 days and the preparation one from home. Actually, she's very much okay and back to me. So you can see the twist in this case that I had to put in to be authentic for this case. That was not in the initial manuscript that I shared, but this happened. Misoprostol safety, it can be effective in second trimester termination in scarred uteruses. By uteruses, I mean previous hospitalization and close monitoring. The risk of uterine rupture is there, but not negligible. And there's it's good to start with lower doses. And there's so many patients. So we're going to see more terminations required in patients who have previous cesarean sections. Misoprostol, as you know, has some expensive, room temperature stable, and can be used through fluids, oral, vaginal, sublingual. Literature insights, low-dose misoprostol is effective and safe in scarred uteruses, but of course, we have to be very careful with the dosing and the monitoring. This is by Begrela et al. In 2019. In that study, they did a whole hospital assessment, and they found only a 0.4% rupture in one previous case. Among their 2 previous cases, they didn't have any rupture, but they had, of course, a 50% rupture rate in patients who had classical CS scar, classical in the uterus, by that I mean. So, and dose escalation increases the risk of rupture. So, about D&E versus hysterotomy, the second trimester has a higher complication rate than in the first, of course. Serious complications are still there, but rare. And D&E is safer with ultrasound guidance and in experienced hands. And D&E is also a viable and safe alternative to hysterectomy, but you have to be very cautious and monitor the patient very closely post-operatively, as we saw in our case. Care and caution has to be exercised. Any complications should warrant immediate imaging, and it's always good to remember to image the original site of the procedure. Remember that our patient didn't have any abdominal complaints, not with bleeding, had chest pain, but we decided to image the original site of procedure. Risk of amniotic fluid embolism has to be remembered. It's rare, but can be potentially fatal. Clinical recommendations is don't limit options to hysterectomy only. Customized treatment based on history and consent. Ultrasound-guided evacuation and further close follow-up enhances safety. Ensure availability of surgical teams for emergencies. And strict follow-ups in the ward and immediate interventions in case of complications. And document consent with risk of rupture, perforation, and embolism. So in conclusion, misoprostol and D&D are viable for TOP in previous scars, but requires vigilance, low dosing, or surgical readiness. Possibly, maybe our patient had not rushed to do for her destructive D&D. Maybe she should have explained. And ultrasound guidance is crucial for safe D&E, and patient counseling and individualized care is very essential. Of course, very controversial discussion, but had to be had due to the global CS rates that are skyrocketing right now. That's the end of my discussion. These are my references. Thank you.
For the COG Central Symposium, Dr. Khadija wins apewe makofi, si ndio? Cases. What Dr. Khadija has actually shown is that the normal things we do, we actually need to be presenting them. Now, first document them and present them, because that's what creates the local data knowledge. Tuache kuquote America, na Europe, na SR, I don't know what. Yeah, we can quote them, but as we collect more data. I think Aga Khan University have started with local data collection. Maybe we need to set up how do we start collecting our data. Our pre-intern project can actually do that, use them, misuse them to collect data and write notes. And amwalipe kidogo. Nyongeza, question. Where, appear microphone, tafadhali. Where is that microphone? What's that? Khadija, stay on. There is a question coming up.
Yeah, this one, Khadija, I don't know whether it's a question or a comment, but let me talk. It has been shown that using misoprostol alone in termination of pregnancy in second trimester actually results in failure or prolonged duration before you achieve the termination. And there are some authorities who actually have achieved success when you combine both mechanical induction and misoprostol. It can be administered at the same time, or you can give catheter induction for, like say, 24 to 48 hours before using, before starting misoprostol, and that one results in higher success rates. I had a similar case somewhere where I was working, those sides of Mombasa, using misoprostol alone in our 2 previous car, and actually it resulted at 20 weeks, and we had a uterine rupture. We had to go in, and whatever we had tried to avoid, we ended up doing it. All of that uterine rupture using misoprostol over a prolonged period of time, because the cervix was just not dilated. And so we learned that lesson, that use of mechanical induction results in more success.
Nicole?
Thank you, Dr. Khadija, for that wonderful presentation. My concern is in terms of just, were there any clinical signs or symptoms that really pushed you towards going towards doing a laparotomy, in terms of were the vitals dropping? Because you find that sometimes if you have a small rupture of the uterus, for us, sometimes we do laparoscopy, we say it can heal by itself. We really don't need to intervene, especially if there's no active bleeding. So, and then at what point during the laparotomy, how much was the hemoperitoneum that you found in the abdomen, just to justify that there was need to go for a laparotomy? And do you feel this rupture happened because of misoprostol or during the dilatation and evacuation? Might we have created that during the procedure? Thank you.
Thank you very much for the comment and question. Yes, Dr. Wafula, it's true. We combining mechanical plus pharmacotherapy with more leaning towards mechanical is actually safer. Her cervix was fully closed, so we had to get it open a bit, then we put the catheter. So Dr. Icole, thank you very much for the comment. Yes, number one, the reason I decided to go in is that, we have had perforations even in regular DNCs in first trimester, and we don't do anything about it. But this patient, remember, the platelets were dropping, HB was dropping fast, and the chest pain was also worsening. I actually thought of amniotic fluid embolism, and I was already looking for ICU space, but the CTPA was normal. So I thought this must be the abdomen. So, and when you repeated during that all mess of doing the CT scans and everything, the platelets had even gone further down to 80. So I could not risk that. It was a very innocent, small perforation, but in a vascular area. And there was a vessel that was shooting. Hemoperitoneum, more than 500 mils. One of my pre-intern mentees, Dr. Kevin Mushiri, I can see him in the room. He was in theater with me, and he was able to say, "Hey, the patient is so stable, Yeah, so, and yeah, the perforation was definitely caused by the evacuation. It can be a bit aggressive because you grab a leg and pull out, But, and I think I focused too much on the posterior wall. Because I was focusing on avoiding the anterior wall. I was like, anterior wall, don't touch unless there's something, because I was scared of the 3 previous scars. So that aggressiveness towards the posterior wall, it was a lesson to learn and has to be shared. Definitely caused the perforation, maybe during the end curettage. But otherwise, had it not been bleeding, should have been stable and will have followed up the small bone fragment, maybe through hysteroscopy later.
First of all, the guidelines talk about misoprostol being safe for previous deliveries of scars less than 28 weeks. Now, my concern is we don't accurately date our pregnancies in most of these settings. So Just as a comment and maybe as a question and maybe to ask everybody's experience, what measure, as standard of measure, do we use before administering these doses? Is this the dates or is it the fundal height? Because personally, I think the fundal height will be a better measure. Thank you.
Thank you, Daniel, for that question. Yeah, I think for me, safely also fundal height. And also start small, yeah? You don't need to follow the figure chart to the dot, especially in a previous car, yeah? Because the figure says 400 micrograms, but if 200 microgram, if 100 can work for this patient, to at least open that cervix for you to insert a mechanical method, then why not? And I think this case is also an important, it really emphasizes the need for us, not just to share our success stories, but also to share our failures and areas where we have learned our lessons so that others also can be more cautious in the next patients. Yeah.
Thank you very much.